It takes a second.
Hello.
There it goes.
Hi everyone, my name is Angie Shimwell and I'm a board member. This is my husband, Nick Shimwell. We started our journey in 2006, right after we got married. And we started trying right after we got back from our honeymoon. About 6 months later, I started having lots of stomach issues and stuff going on. We thought I might have been pregnant because I hadn't had a cycle. Turns out that I had severe acid reflux. So our regular doctor did a bunch of testing, and she didn't find anything between the both of us. She had ran tests on him and me, and we couldn't find anything. So she referred us on, and we saw a lot of doctors in between 2006 and 2014. We did 4 rounds of Clomid. We did 5 failed IUIs. We did 1 IVF cycle. In 2013, we did an IVF cycle, and we retrieved 18 eggs. We were so excited, 18 eggs, and we put back 2, and we had 6 that we were able to freeze, and those 2 took. So we had twins, and a few weeks later, I was hospitalized with ovarian hyperstimulation, the worst case my doctor said that she had ever seen, or one of the worst cases. I had 11 liters drained off my belly. I had 3 liters of fluid drained off my chest, and but everything was going good. The twins looked fine and everything. We were released a week after being in the hospital, and a week later I miscarried them. So we still had our 6 frozen, but at that point I literally went into seclusion. I didn't want to be around anybody. I didn't want to go to work. I didn't want to talk to my own mother, who's my best friend. And so we took some time, and our doctor finally talked us into trying again with one of the 6 that we had frozen. So we put 2 back in April of 13, and that failed. Put another 2 back in June, and our numbers rose, and then they dropped. So I guess they consider that a miscarriage. At that point, I was like, oh, we need a summer break. We had been through everything, and I was like, we need a break. And so we tried again in September, and my numbers, they rose, but they weren't doubling like they should be. And so finally, after a week of them rising, they finally started to drop. So at that point, we had exhausted every penny, every insurance policy we had, everything. We looked at each other, we were done. We had been at this since 2006. It was October of 13, and we were just done. And we had 2 anonymous angels contact us and said, we've been following your journey. We don't think you guys are done. We'll pay for an IVF cycle, you pay for the drugs, we'll pay for the cycle. So after a lot of praying and talking to our pastor and our doctor and each other, we said, okay, let's do this. So at that point, I decided, okay, God's given us a second chance. And so I told our doctor, I said, okay, it's in your hands. We're going to do whatever you want. I'm yours. You tell me when to be there, what I need to take, I'm yours. I'm kind of a control person, so to let go of that was really hard. And so we let go, and this time she's like, we're not going for a lot of eggs. All we need is 1, and we want quality over quantity. We retrieved 8 eggs. Of those 8, 7 survived. And so on transfer day, we transferred 2 back in, and then we have 2 frozen. And we welcomed a little boy in last July.
Well, we almost welcomed a little girl.
Yes, we actually almost welcomed a little girl. Our doctor, our OB said, you're having a girl, all the way up until 30 weeks along. Had 2 showers. And went for a 3D on our own, and she's like, who told you it's a girl? We're like, her doctor twice. And they said, no, that's a boy. Ian was born 4 weeks before 8 years of trying to have a baby. And he's our little miracle. And the best advice I can give anyone is to not give up, because had we given up, we wouldn't have him. And when you're choosing your doctor and when you're going through all this, my other best advice is your infertility doctor is like your friend. You either click or you don't, and it's okay if you don't click with that doctor. But if you have to see 10 doctors before you find the one that clicks with you, do it, because that's what we pretty much did. I can't even begin to tell you how many different doctors we saw, between OBs, regular doctors, chiropractors, acupuncturists, RE doctors. If it's out there, we tried it, we did it. And we finally found our fit, and she had given us some information that no other doctor had informed us about. We found out that I was very deficient in vitamin D. We found out that I had a tilted uterus. We found out that I had some scar tissue down there from a surgery that I had years ago. There were just a lot of things that no one had ever told us, and it contributed to our infertility. So make sure you find that doctor that you click with. That's just the best advice that I can give any of you, even if it takes you seeing every doctor out there and it's the last one. So
I don't have much to add, you pretty much covered it. My only advice, especially as the spouse, is just be there, support them. I'm kind of have a dry sense of humor, and I try to keep somewhat comedy in it, because let's face it, some of the things we have to go through in infertility it's private stuff, but you just keep a light heart. That's all I can say. I mean, my buddies would just laugh because I tell them some of the things we had to do. That helped me, and it helped us. So just keep fighting, because we were inches from quitting. I mean, I'm an old man. I'm not going to say my age, but I'm tell by the gray and the goatee. But I was like, I'm done. We're just not going to be parents. We'll figure something else out. We'll have dogs, but I wouldn't trade that little boy for anything. I travel for a living, and I can't wait to get home to see that kid, so keep fighting. So.
Other than that, the biggest thing for us is we found the conference in 2011 when it began. We came to the conference. I literally drug him kicking. And it was the best thing we ever found. Before I became a board member, we attended the first 2 years. And to sit in a room and to realize you're not alone. And then on top of that, that's when we started opening up to our friends and family and letting everyone in. And that is the biggest help you can get, is letting your friends and family be there to support you. They may say stupid things. I will not mention names, but we have someone that told us after our dog passed away, said, well, now you can concentrate on having a baby. So they're going to say stupid things, and you just kind of look at them and laugh. And I know they mean well. They'll never get it. They've never walked in our shoes. But your friends and family are going to be your biggest support. And then all of us at KCIA are a huge support for you guys. Anytime you need any of us, one of us has been through what you have been through. I know every single infertility case is different, but one of us has been through something similar, and we are all here to help you with your journey and help you achieve your little miracle.
Thank you, Angie and Nick. All right, we're going to go ahead and get started with our speaker. All right, please help me in welcoming Dr. Celeste Furrybeck from Reproductive Resource Center. She's going to be talking about in vitro. Is it for me? Thank you.
Absolutely. Good morning. And again, welcome. We're so happy that you're here. I hate being behind a podium, but I think I need And again, a thanks to the Shimwells and all of those who are sharing their stories and all of those who are here today. It's not easy to be here. Before I was in Kansas City, I was on faculty at Creighton University in Omaha. And right as I was leaving, my business manager said, "Can I talk with you before you move to Kansas City?" And she said, "You know, my husband and I have experienced infertility for like 8 years." And I said, "Oh, you never said it, that has never come up. You never shared anything with me." And she said, "We were both too afraid. We were paralyzed by our fear. We didn't find out, is it her fault? Is it his fault? What are they going to tell us? What are we going to find? Will the treatment work or not?" And so I want to just take a moment to commend all of you for moving past that, because you had to be here today. To say, hey, let's at least go find out some information. Be open to that. And no matter what journey we go on, we might find success, we might find failure. But I think one of the goals as a fertility specialist that we certainly have is that 10 and 20 years in the future from now, whether you have a family or you do not, certainly my personal goal for you is that when you look back, you'll be at peace, because no matter what happens, we hope that you'll find, hey, in 2015, we got good information, we tried to research, we did the best we could, doctors and ourselves, we found all the things that science could possibly do, and I think we can all be at peace with that, all right? The great news is though, and you really need to hear what I'm just about to say, is that almost all of you are going to have success and get that baby, okay? What treatment exactly it is going to take to get there, I could not tell you right at this time. Those are individual little steps, but I'm going to tell you, almost everybody will take home a baby. Sometimes it requires us opening our heart and opening our mind a little bit to things that at one point in time that, hey, that doesn't seem right for me, or I don't want to consider that. That may stay the same, and you may choose to draw the line in the sand, or you might say, oh, maybe I should be open-minded and learn a little bit about it. So today we're going to talk a little bit about IVF. And IVF sometimes we think of as, oh my gosh, that's that really big, expensive, high-tech thing, and you do shots all the time, and there's all those multiple babies, and so let's not go to that session. I don't want to hear anything about it, because I don't think that's anything that we need. And one of the goals I have today is that, hey, many of you will not need IVF. Many people do not. And certainly our goal for you is to find the cheapest, simplest, easiest, fastest way to get you to take home a baby before hopefully you're too emotionally fried that you're going to say, oh, throw in the towel, let's buy a boat, get a dog, take a trip, or whatever that might be. Because if you go that far into it, then it starts to really, really become tough, okay? And so for some people, IVF might be one of the things you might want to consider, and one of the reasons is because it's a really great efficiency model. And I'll explain why in just a few slides, okay? Allison, what do I need to push to go forward? Because I'm pushing this, but nothing's happening. Is she in here? Okay, we're going to try that one. Okay, so IVF, what is it? There's all kind of this alphabet soup when it comes to infertility, which can be very confusing. But in a nutshell, IVF just stands for in vitro fertilization. In vitro just is fancy words for meaning in the lab, as opposed to having romance at home, which would be in vivo, okay? So in vitro just means things are happening in the lab, all right? IVF beginnings. First IVF baby was born in Great Britain in 1978. At the very, very beginning, we used to put in a transfer every single embryo that there ever was. You put all of them in. And at that point in time, you're really lucky if you have maybe a 10% pregnancy rate. So things have really super evolved since then. Where now we do ICSI, where we inject sperm into egg, and now we're growing out embryos longer, and we have safer and better freezing techniques, and can freeze eggs, so a lot of things have happened in that time frame. Initially, IVF was used for women who had blocked tubes or had their tubes tied, so that was the original reason that anybody did IVF. That was the one and only reason at the very beginning in 1978. And now what has happened is that it has evolved to treat many, many more factors. So, male factor, endometriosis, unexplained infertility. IVF is a really good treatment for unexplained, and I'll explain in just a few slides. Recurrent pregnancy loss, also known as miscarriage or recurrent miscarriage. IVF is really a great treatment for those things. In 2012 alone, more than 65,000 U.S. births occurred from IVF and ART kind of procedures. So these are certainly not brand new, experimental, nobody is doing it. And the CDC reports 12% of women of childbearing age have used infertility services. So that's a lot, so don't feel like you're alone. Some people, as you heard from these panels, really like to share. Some people want to keep it private. I don't think there's a right or wrong. I'd say you got to listen to your own heart, and what's right for you is right for you. And as a couple, just talk with your partner to think what they think is best. So here we are 37 years later, and over 5 million babies later. Over 5 million babies from IVF, and over half of those have happened since 2007. So here we are today, and a lot has changed, so we'll talk about that. So things that we already know, and things you probably know, would be who needs IVF? So again, we know if the tubes are blocked, the tubes are tied, the tubes are surgically absent, they've been removed from an ectopic and those sort of things. So we know, hey, you need IVF because obviously the tube is where the egg and sperm meet. That's where fertilization happens. And so if fertilization is supposed to happen in the tube and the tubes are tied or blocked or diseased, then the IVF lab is a great place as a substitute. So that's IVF. And we know that if there's really severe male factor infertility, including males who have a history of vasectomy, IVF is very effective. You do not need to have a vas reversal. We know that those couples need IVF. But I have a couple scenarios here that I'm going to utilize just to kind of as a points of illustration to say, hey, these are things that you might know, but you might not know. That say, hey, you know, this might be somebody who sounds like you or somebody you know, and where maybe IVF is something we should look at on the menu. Sometimes it's like, okay, you're out at a restaurant and go, okay, I just want salad and soup today, and I'm not even going to look at the sandwiches or steak or whatever, and you don't even flip to that page because you're like, no, that's not in our budget, I'm not really that hungry, I don't think I'm really into that. And then, you know, right after you do the soup and salad, and, you know, and pay $9.99, you realize that for $12 you could have the steak and lobster and dessert and coffee and dancing and champagne and a little chocolate at the end, and you're like, oh, I wish I would have known about that because maybe I would have chosen that one. Maybe I would have chosen that one. So I'm going to present a few scenarios. Scenario number one, and I just gave these names. So Mike and Sarah, we actually have a nurse named Sarah, and her husband's Mike. She used me for scenario one, so I used her for scenario one. These are just made up names. Couple trying to conceive for 2 years. Again, in this fictional scenario, female partner's age 25, so young. Irregular periods, sometimes you know, a scenario we call PCOS, high antral follicle count, a lot of little follicles, and some of you may know what I'm talking about, some of you will not, but high AMH, those are markers that would suggest, hey, there's a lot of eggs there. But like one of our panel couples, the eggs aren't leaving the starting line of the race, they're just kind of all hanging out at a really immature stage. In this scenario, the semen analysis is normal, the uterus and tubes are normal, and this particular couple has undergone 6 cycles of ovulation induction using things like Clomid or Letrozole, and they've had some cycles of oral medication with a reproductive endocrinologist. In this particular couple might feel like, gee, I want a baby, but I don't want multiple pregnancy. I really don't want free diapers in a free house for life, and I don't want a TV show like those other people. And so what do I do next? I've done all these things, right? So this is someone who would be a good candidate to consider IVF, even though the tubes are fine and the sperm's okay, and certainly there's eggs there. And one of the reasons is that the next step in between doing some oral medications and IVF is using higher dose fertility medications. But one of the problems with those is that it's less expensive than IVF, but one of the fears and one of the risks of that is high order multiple pregnancy. And ultimately, even though it costs less at the beginning, 9 months from now, or 6 months from now, or 7 months from now between preterm labor and neonatal cost, and that sort of thing, all of a sudden you're like, oh man, when I add all that up, I could have had a really high chance of a singleton baby doing something else in a different scenario. So this would be a scenario that would be a really good candidate to at least consider option of doing IVF. Scenario 2 is our fictional patient Rachel. She is a female, age 30. She's had 3 laparoscopies for endometriosis and has been told she's got really severe endometriosis. And so she presents saying, hey, you know, I did really well after my surgery. I was on Lupron or birth control pills because anytime I'm off of Lupron or birth control pills, I have a lot of pain, and then the endometriosis comes back, and then I end up with another laparoscopy. So this is someone who really should think about doing IVF sooner rather than later. And the reason is this, that she's 30. The average age of menopause is 51, okay? So is she gonna have like another 20 laparoscopies or 10 laparoscopies? If she does one every other year, it just doesn't make any sense. And so when we look for situations where efficiency is key, in other words, she's gotta come off the pill or come off the Lupron to try to have a fertile period of time in her life, then we need to find treatments that have a really high chance of success so now a long period of time goes by, right in between coming off of a Pelzer loop run and trying to have a baby, before she hopefully doesn't ever need that fourth laparoscopy or fifth laparoscopy, because there comes a point in time where it just doesn't make any sense. Okay, so significant endometriosis is certainly a reason to think about doing IVF sooner rather than later. Scenario 3, Maria and Arthur. This is a couple who comes and say, hey, we're not infertile. We have been pregnant 4 times, we do not have infertility, and we've had 3 first trimester miscarriages, and then we got pregnant with twins, and so we do not have infertility, and but unfortunately we had preterm delivery of the twins, and unfortunately they passed away. 33-year-old female, again recurrent miscarriage. This couple reports saying they're really fearful. They don't want multiple pregnancies. They want a baby, but not a litter. And they're also fearful of an unhealthy child, given that kind of history. So this is somebody who, this couple also would be a really good candidate to think about IVF, because very high pregnancy rate in a very short amount of time. The newer technologies allow us to test for viability versus non-viability, allow us to put in 1 embryo, and is a really effective way at reducing the chance of a miscarriage. So recurrent pregnancy loss would be a good reason to think about IVF for yourselves. Next scenario, Anna and Mark. She's 38. Some of her blood markers talking about egg quality, egg health and age-related infertility are not normal. Semen analysis is a little bit low, and this couple has, hey, 1 tube is blocked. So there's a lot of different things that could work, and always, it's never, I never say never. Seldom is someone going to say, hey, trying on your own, it can't happen. So, yeah, I never said, could it happen? Yes. There's a likely, and then there's a more likely, and then there's a less likely. Certainly, as you're falling in the less likely, then one of the things as fertility doctors we're probably going to counsel is, hey, think about doing something with high efficiency model, because otherwise you're going to burn out. And time is really never our friend. Time's never on our side, because as many of you know, time is one of the #1 factors that affects egg quality and ultimately pregnancy rate. It's more important than all the other factors. So as we see a female partner increasing in age, we really want to consider this. We now have data that says, hey, pregnancy rate and egg quality starts to decline around female age 25, not 32, not 35, not 38, not 40, not 42. Average age of menopause is 51. So, and sometimes we'll see women who, hey, their last baby isn't 38 or isn't 40, but it could be a little bit younger. So we certainly see in unexplained infertility, oftentimes we'll find out, hey, you know what? The unexplained is explained. And the problem is, it's an egg quality problem, even though you could be young and beautiful and healthy and everything seems absolutely normal, and all your family and all of your OB/GYN saying, hey, nothing's wrong, just keep trying on your own. If you actually have a little bit more evaluation by a reproductive endocrinologist, you might find, oh, actually, we don't have a lot of time, and actually maybe we better hurry. And sometimes you'll find, hey, we've got significant egg problem even in a younger person. And the thing about this one is this can be totally asymptomatic. I mean, at 38, we probably know, hey, there's an age-related kind of issue. But sometimes we'll see it that absolutely is asymptomatic. And so if you're unexplained, you want to think, hey, that might be what it is. Because if we had to uncover and unveil what is causing the unexplained, it's almost always gamete problems, egg and sperm. It's more common egg than sperm. Nothing's wrong with us ladies. It's just that, quite frankly, we make 1 egg every 30 days, okay? Men can make 1 to 10 million sperm every day. Then there's another 29 days. So it's just the way that nature has designed us. So men make abnormal sperm too. It's just that you got lots of backup. Okay, you got lots of backup. So it's just kind of the way that it is. Scenario number 5, again, unexplained, as I just kind of talked about a little bit. So let's talk about some of what we call forever guidelines. And Susie Orman does this finance show, and she kind of has this like forever guidelines. These are things about your finances, like you should never spend more money than you make, and things like this. But I think these are forever guidelines, and most couples, when they present to a fertility doctor, almost always want this, like we do at Christmas. We want a wish list of here's all the things that we want. So usually we want to be pregnant yesterday. We want something very efficient, because as couples are starting to burn out, we heard all these couples up here saying, oh my gosh, and sex can become, it's romantic, but it can become, it's so goal-oriented, it becomes a job. And we certainly see couples trying to have a baby probably have sex less often than couples not trying to have a baby. It's no longer fun and exciting and to do. As a matter of fact, some couples say, oh gosh, let's not even do it. Because if we do it, and if I have a little bit of breast twinge, and a little, something, then I think maybe you know, we kind of think people are pregnant, and then we get all excited, and we better just to say, hey, it can't be because we didn't do. So efficiency is a huge thing. Most patients and doctors want this low risk of this ovarian hyperstimulation, and you heard the Schemmels talk about that a little bit. One of the other couples on the panel talked about that a little bit. That's a condition where it's a short-term thing, but temporarily some women who do fertility treatments, the ovaries get big and get a little bigger than average, and it makes a little fluid in the tummy, sometimes fluid in the lungs. So doctors don't want this, patients don't want this, so we want treatments that have a really low chance of that. Everybody wants a really high chance of taking home a baby. Okay, high pregnancy and, more importantly, live birth. We can't just get a pregnancy and a positive test. We can't just get a pregnancy and the ultrasound that shows a baby, or a heartbeat, or get to 12 weeks or 16 weeks. We got to get all the way to the touchdown. Low multiple rate, patients and doctors want that. Sometimes patients want twins. We always want one. Sometimes we'll put in 2 embryos to try to get that one, but as doctors, our goal is always 1 baby at a time. Patients and doctors want a low miscarriage rate because, of course, it's so devastating to kind of get there. High chance of that full-term healthy baby. And again, as I alluded to just a moment ago, time is unfortunately not on your side, okay? So again, we start to see fertility wane in our mid-20s, and so you just want to be cognizant of that, because again, at the end of the day, you want to say, hey, you got good information, we made good choices, we didn't delay too long, you're your best advocate. So you kind of want to be moving along, kind of thinking, hey, what do we think is going on? Let's try to identify those causes and factors so that we can knock them down, jump around them, go over them. What do we have to do? You want to really find out what is thought to be the cause, so that way your doctor and your team can strategize in your particular case what it's going to take and what it is in between you and that baby that's standing out there in your future for you, okay? Scope of infertility, of all couples, it's about 1 in 10 couples. You can see on here as you get older that becomes much more common, okay? Again, because we have aware of this age-related thing in infertility. In about 1960, give or take a few years, that's when the birth control pill came out. And before that time, the average age of getting married was within 6 months of graduating from high school. And the average age of the first baby was less than a year after that. So we just totally have a different scenario now. And with medicine and modern medicine and this option of contraception, it's very empowering to women and to couples to say, hey, maybe I want to go to school, maybe I want to be a lawyer, maybe I want to be a doctor, maybe I want to travel, maybe I want to save some money, and all those are wonderful things. It's great for social purposes, it's great for maturity, do what you want to do, but biology is kind of a problem. So now we commonly see, hey, we're kind of waiting a little bit longer, okay? And again, I was petrified to know that I was 36 before I ever got done with fellowship. And oh my God, I wish I didn't know what I knew, because I was like, oh my gosh, I am way, way beyond a good place, okay? This is just a graph showing monthly fertility rates as a function of age. So in a fully fertile couple, it seems to us as we're trying to have a baby that, my golly, like the panel said, everybody on Facebook is announcing a baby and their second baby and their fourth baby, and your neighbor and your sister, whatever it is, and ha ha ha. She was on the pill, and we just look at each other, and isn't that so cute? It's like, oh my gosh, gag me. So you need to realize it's not 100%, and even when everything is perfectly functioning, fully fertile couples in our 20s, chance of pregnancy 1 month is 15%. So we gotta get our expectations a little bit different. If our expectations are, oh, it's gonna be 100%, you don't have there's not 100%, nature doesn't have 100%. No doctor on the planet, no doctor in the world is gonna give you 100%. So fully fertile in our 20s, 15%. Look at where it is by 35. 9. Okay, 9. Oh my God, I was 36 when I finished fellowship. Everybody's going, oh my God, this is not good. I'm beyond, I'm under 9. This is not good. And by 40, it's under 1. That's in 1 month. So those are not good efficiency models. So you have to kind of think and get an idea, hey, this is what it is if I'm doing, this is in a fully fertile couple. Infertile is a different situation. And then to understand, hey, what's the pregnancy rate with the different treatments that doctors have? Because you need to understand that. The reason you understand that expectation is everything. If you're offered a job and they say, hey, we're going to pay you $1 million a year. I go, oh, that sounds pretty good. I'll sign up. I'll start Monday. And then you only make $850. You'd be like, dang, I was going to get $1 million. I got $850. I'm not happy. So, you got to realize it, understand, hey, here's kind of your basal rate, fully fertile, what's your basal rate doing nothing, infertile, what's the chance of it's going to work in any treatment? Because that gets you an idea, what's the chance going to work, what's the chance it's not going to work, a sense of what expectations are, because that is so important to understand, okay? This is a graph of why eggs are often a part of the problem. Sad to learn, this is a very sad day in my life to learn, oh my gosh, I had the most eggs when I was a 20-week fetus in my mother's womb. And that's the truth. So that little red peak at 20 to 28 weeks, that is before birth, if you notice. Birth is over there at 40 weeks. So we are losing eggs by the day and week before we're even born. Like, that's just how it is. And you can see at birth we have a certain number, and then that is declining. It's declining before puberty, and the sad thing is egg quality and egg quantity continue to reduce even when we're not ovulating. So some people say, hey, PCO, this is great because I don't ovulate, so I'm saving. Am I never going to be right up there because I've never ovulated? Not true. I've been on a birth control pill, I've never ovulated. I've been on Lupron. I have been pregnant 3 times, and so during those months, I did not ovulate. Unfortunately, the passage of time still occurs, DNA still degrades, and egg quality and egg quantity are decreasing, and no doctor has discovered anything yet that can change that. This is just a little circle that again shows us that, hey, you know, hey, at age 25, we start to see, if we really look at the numbers, that monthly birth rate starts to decline. So it's 25, it's not 30, it's not 40, it's not 42. So, you know, hey, by age 30, it's like, oh, holy God, 12% of eggs remain. That doesn't sound very good. And then we have egg quality issues on top of that. So it's one of the reasons why we commend all of you for being here. We thank all of our team members for volunteering their time today, because information is power to you. Information is key. You've got to get information, because with that, then you can make decisions that are appropriate for you, okay? So that's a really key thing, and then you can decide what pathway. You want to remain child-free? You want to do a treatment? You don't want to do a treatment? You know, what is a good fit for you, okay? So again, another graph that just says, hey, optimal fertility looks like, hey, it's in our 20s, unfortunately. In our 20s, sometimes we don't have a partner. We don't have a job. We don't have a house. We have nothing saved. We you know, may not just be able to happen. I remember in training, one of my the teaching physician said, well, when are you gonna hurry up and have a baby? And I said, well, I'm not even dating anybody right now. How am I gonna do that? I just wasn't ready for donor sperm at that point in time. So, you know, not to scare, but to say, hey, the graph, and it's not a linear graph, it's a logarithmic fall. So it's kind of like, So you just want to be a little bit aware of that, okay? Here's a, not exactly perfect, this is not exactly perfect, but it gives you a little bar graph scope of kind of, sort of, again, guesstimates of what different treatments look like as far as pregnant rates go. So you kind of have some idea. And in a fully fertile couple, 15%, again, that's in the 20s. By 35, I showed you it's about 9%. Infertile, you put all comers in that one with no treatment, doing nothing, it's 2%. If you do like IUI without Clomid, or Clomid itself without IUI, just having intercourse, it's around 4%. So that's twice doing nothing. It is FDA approved, Clomid's FDA approved. But hey, that's what your expectation is. So I like to flop that number around the opposite way to say, hey, that is a 96% chance it is not going to happen in 1 month. That must be your expectation going into that. If you do not understand that, or don't like that, or don't want that, then this is not a good choice to make. So that if it works or doesn't work, you know, at the end of the day, you're not like, oh my gosh, I can't believe it didn't work. I'm devastated, this treatment is not good, it's never going to happen, because that would be, we need to understand those expectations, okay? So many times fertility doctors will start out treatment typically doing some oral medication plus IUI, because the two together look like they have a little bit of what we call synergistic effect. That means the two together, the pregnancy rate of the two together is higher than the addition of just Clomid or just IUI, or Clomid or letrozole, whatever medication a doctor might use. So oftentimes that's a good starting point to be some kind of oral medication and IUI. And you can see as you add injection drug and some of the stronger fertility medications, pregnancy rate goes up, but it doesn't go up a ton. Cost goes up because when we get into the next tier of fertility medications, unfortunately, at this point in time, they're only injection, and they're very expensive. So once you go into the injection medications, one little vial often may cost $50 to $100 for one vial, and you could be on one vial, 10 vials, or whatever in a month. So all of a sudden, medication cost goes up when you go into that category. But you can see the pregnancy rate is higher, but it's not tons higher, and that's can be a little bit dangerous, because sometimes that's a scenario where maybe you'll make too many, maybe you'll make not enough. And if you make too many and get canceled, you're like, oh gosh, I just spent all that money on those injections, and I did those shots, and now here I am, and now we got to start over. So we have to be a little bit careful about what should be the hierarchy of where you go to your next step, okay? This is a graph just showing you how many times do I try. The point that I want to illustrate in this slide is that the vast majority of pregnancies when we use oral medication and IUI will happen in about the first 3 treatment cycles, okay? So you can see on this graph, this is not, again, this is a little guesstimation, but hey, like 40 to 50% of couples got their pregnancy within the first 3 treatment cycles. The point I want to illustrate here, and it doesn't totally flatten out after that, but the graph, the line does not keep, we never get to 100. No matter how, either you can make this 6 cycles, 9 cycles, 12 cycles, 18, whatever you want to go, we never get there, and it starts to plateau out. So for many couples will say, hey, let's think about doing 3, 4 cycles of oral medication and IUI. After that, hey, you kind of got your max. Could you still get pregnant? Absolutely. Could you get pregnant doing nothing? Absolutely. But it's time to consider, maybe it's time to think about, should we switch to something else? Again, because every month, even though we know those expectations I just talked about, even though we know it's 10 or 12%, and I know we all know that, and we look at the graph, and our head and our heart and our mind is still like, oh my gosh, we're so in this, and we want it. When it doesn't happen, it's just so devastating, okay? So there does come a point where we have to say, well, let's think, what else might there be? Is there anything else that gives us a higher chance? Risks, you want to know them. Because again, the step in between oral medication, IUI, and IVF is a little bit risky. We do it, we just have to be careful. We need to know, are we just trying to get 1 egg? Because sometimes the oral medications, we can't even get 1 egg, so we got to go to something else to get the 1 egg. Because if there's no 1 egg, we don't have a picture on the mountain, it ain't happening. No matter how many times you have relations and how you time it and all that sort of thing, if there's not 1 egg. But if we get too many, then again, we're really not trying to get a multiple pregnancy. Okay, again, we're trying. So you really want to be a little aware of that. So this is just a little illustration about kind of what IVF, this is a little summation, and then I'll break down into little steps of IVF. So step 1 uses fertility medications, and when we do IVF, we purposely, most doctors will purposely superovulate you. What does that mean? We're going to use medication to purposely make a lot of eggs. Now, I just said we want 1 baby, and that is true. But what you need to realize, the chance that any 1 egg is good and healthy and chromosomally normal is not very high, okay? Just not very high. The older you get, the worse that is. And as your FSH gets high, your AMH gets low, and all sorts of answer AFC gets low, all these things, it becomes worse. So it takes probably maybe a dozen eggs to maybe get a 50-50 chance of a pregnancy at the end of the cycle when we put an embryo in, okay? So we purposely try to make many. And one of the things that we can almost equate that to, is, okay, if you got, let's just say you got this theoretical dozen eggs for the sake of an argument of picking a number, almost equate that to saying, oh my gosh, that's like squeezing in 1 whole year of trying into 1 cycle. That's about the equivalent, okay? But we can do it, so all those eggs, I get good ones or bad ones or whatever they might be, I kind of get a whole year's worth in one shot. That's pretty good. Because some of those will not be good, some will not fertilize, some will be abnormal. And we don't have to worry about having 12 babies, because when we do IVF, because we remove the eggs, that's a little outpatient procedure, and I'll talk about that in a minute, but you have control, so does the doctor. How many you want to put? 1 or 2? I mean, we're not going to put in 7 or 5 or any crazy thing. So it does provide, it's kind of like you want to win the lottery, if the baby wins the prize, and you want to buy 1 lottery ticket, or do you want to buy 10 or 5 or whatever it is, to like, oh my gosh, we need to get this elusive prize, okay? So anyway, use medications to superovulate, monitor blood work and ultrasound. There's a little surgery to get the eggs out. That usually takes about 10 minutes in the operating room. There's no incisions, it's not a laparoscopy, it's outpatient, you go home the same day. Eggs and sperm go together to go 5 days, and typically the best 1, sometimes 2 embryoes per back in the year. So that's the summary, and I'll kind of go through each thing. So phase 1, ovaries are stimulating medications. Again, commonly these are the injection medications because, again, our goal is 1 baby, but to get there we often have to actually superovulate to get there. And then gently aspirated under transvaginal ultrasound guidance. So the same ultrasound that you might have been monitored with for Clomid or letrozole or whatever might be in your doctor's office. Again, that's an outpatient procedure, IV anesthesia. You're not under general anesthesia, you're not paralyzed, it's pretty fast. Eggs and sperm are put together in the IVF lab with either standard insemination, that means 1 egg is put in a droplet of a couple of, 100,000 to 200,000 sperm, or a single sperm can be injected to the egg. And next day, eggs are checked for fertilization. So step 1 is kind of medications and getting that retrieval done. A couple very key points is that I showed you a picture of like an oval with these black circles that kind of look like chocolate chips and a chocolate chip cookie. And so commonly when couples are doing one of these stimulations, you're like looking at the ultrasound, oh look, hey look, I'm gonna get 10 eggs. Oh my gosh, so excited, I'm gonna get 10 eggs. And then You get out the retrieval and go, oh, 8 eggs. Like, what happened to those other, what did you guys do with the other 2? So one important thing is whether you're doing IUI or IVF is that the number of follicles is not exactly equal to the number of eggs. Okay, not every follicle always has an egg. So again, these are important things to understand so that you are happy with your care team and your expectations are again are in line with reality. And the number of eggs that you get is not equal to the number of mature eggs. So sometimes medication protocols affect this, sometimes it's your genetics and DNA, but no doctor and no medication protocol can dial up a mature egg, and only a mature egg will fertilize. So some eggs will not be mature. On average, about half to 2/3 of eggs fertilize. So, are mature, fertilize. Half to 2/3 are mature. Not every one of those fertilizes. So if you had like 12 eggs, if only like half are mature, you're down to 6. And you're going to put those with sperm, you're going to be down to 3. All of a sudden in one day, you drop from 12 to 3. And so if one doesn't expect that, people might say, gee, what's going on? What did you guys do with my other 9? What are you doing over there in the lab? So this is kind of the reality of the inefficiency of human reproduction. It's just what it is. And this is an IVF lab where we're getting 12. Imagine you in your own life, you're getting 1. And you're looking at these same numbers, okay? So IVF phase 2 is the embryos are cultured in dishes. This is not exactly the size of the dish, but they look kind of like this. In an incubator under very specific conditions of gas, temperature, light, all this sort of thing. And most labs now are doing day 5, or what we call blastocyst transfer. The number of eggs you get, again, is not the same as the number of follicles. And the number of mature eggs is not the same as the number of eggs. Then, through those 5 days, the number of eggs you got does not equal the number of embryos. Unfortunately, of the ones that fertilized on the first day, oftentimes patients will get a call and say, okay, hey, you have this many eggs, and so many were mature, this many fertilized. Well, then you get 4 days to go. Well, the number of embryos is usually much lower. So commonly, only about 40% of those that fertilize will survive the next 5 days. So you can see this is like, oh my goodness, we start with 12 over here, now we're down to 1 or 2. And so people are kind of sweating if you don't understand this, okay? It's one of the reasons, again, that we do superovulation. We don't want 1 baby and then to freeze 10, because you'd be looking at us like, oh my goodness gracious, we want a baby, but how are we going to afford college tuition, and we want to be respectful of life, and don't waste embryos, that sort of thing, because it's kind of what we need to get to an embryo, okay? So one of the next steps in IVF is putting the embryos back into the uterus. Usually you're awake, you're alert, you walk into the room, you walk right out. Most centers are doing ultrasound-guided embryo transfers, so we're going to watch under real time where embryos are placed, and usually that's the best 1 or 2 embryos transferred into that uterine cavity. And then you get up and walk right out. So that's what that kind of looks like. These are some pictures of actually what eggs will look like. So this is actually eggs right after egg retrieval. And the egg is the little dark spot that actually kind of looks like an egg yolk sitting in an egg white, and then all that starburst is what we call the granulosa cells. Those are the cells that support the egg development. Those are the cells that are making estrogen, that have been causing estrogen to rise if your doctor's following your estrogen level. This is again, some pictures of eggs. I always find it kind of interesting how an egg looks so much like the sun and the origin of life, that I think it's just an interesting little analogy that God or nature designed for us. And again, that's an egg as well. This is a close-up of a mature egg, and you can see there's like one little Mickey Mouse ear sitting over there at about 9 o'clock in that picture. And that is what's called the polar body, and that's a sign of a mature egg. And not every egg will be mature. So we're looking for ones that have this polar body to say what are mature. This is a demonstration of ICSI. The bigger item on this slide is a suction pipette kind of holding an egg, and at 3 o'clock is a little needle that is injecting a single sperm into a single egg. And so ICSI does allow us now to treat men with very rare sperm. It allows us to treat guys who've had vasectomies without doing a reversal. We can treat guys who have 5 sperm. Not 5 million, not 5,000, 5. Might take us 4 hours to find them, and sometimes if we do, and our lab is not, and kind of, got to get up and stretch their legs. But anyway, it does allow us to treat really severe male factor. And if we're able to do this in the pregnancy, it's the same as if semen analysis is normal. So these are really nice to know that, hey, these are some techniques that, there's a lot of backup for you. You got severe endo, oh my gosh, maybe we need it. You got really severe male, we don't really want a donor sperm, what else you got? Here's just another picture of ICSI. This is just a little culture just to kind of show you what those might look like. Over the next 5 days, embryos are growing, and not every embryo read the textbook. Okay, so on day 1 it's supposed to be this zygote where it's 1 cell and it has these 2 little Google eyes. That's the maternal and paternal DNA component. It's called the 2-pronuclear. And usually on day 1, it's like 2 cells, and day 4, it's 2 to 4, and day 3, it's 8 to 10, and day 4, it's memorialized, so it kind of looks like a little mulberry, you can't see the cell borders anymore. Day 5, it's this elusive blastocyst, but we see infernal couples every day. So sometimes on day 5, the embryo looks like it's a day 4 or day 3, and each embryo is its own unique entity and its own unique DNA, so that we may see a little variation. Not all your embryos are necessarily going to be at blastocyst stage, even though it's day 5. Okay, and that's just a reality. All right. These are just some pictures. Again, this is a day 1 embryo. It's 1 cell. It has those 2 little Google eyes inside. Again, that's the maternal and paternal component that shows they got fertilized with 1 egg and 1 sperm. If you have 3, then something went wrong. This is next day. Here's day 3, 8 to 10 cells, and then that's a memorial, that kind of mulberry-looking embryo. And this is a blastocyst, so that looks a little bit different. Usually, a blastocyst stage in these days and times is when most centers do transfer. I'm proud to say that our center has been around 27 years, and we have been doing 100% blasts. We're the first in the world to do 100% blasts. And we've been doing 100% blast since I came in 1998, and I think we started about 96. And so it was very risky at that time, because at that time there was no media that was made to grow blast. You had to make your own. Now you can just call up drug manufacturers and say, hey, I need the blast media. But then you couldn't, and it was very risky because you had more embryos in your lab for more days. And so, my golly, you couldn't culture them, and they all died. Your patients are calling you going, they look pretty good on day 3, they're not there on day 5. So, but what we have learned through blast, the reason that this is so important is that, number 1, nature always does it better than science. And in natural life, day 5 is when the embryos are planted in the uterus. Number 2 is that on day 3, a lot of embryos really look good. And so it's hard for doctors and trained embryologists to say, which one do we put in? We don't know which one's better, which one's not better. So when transfer is done on day 3, then doctors are putting in more. You have to put in 3 to figure out probably one of these is good. But if you watch all of a sudden from day 3 to day 5, oh my gosh, between day 4 and day 5, they're dropping like flies. Oftentimes we'll see like, oh my gosh, pretty much embryos are great yesterday, and day 5, we're down to 1 or 2. Exactly what we want. We want to know which one is the best one. That allows us to put in fewer embryos. So this was the first time in the history of infertility that you could put in lower numbers of embryos, and couples walked home with a higher chance of a live birth. So it's a huge, this blastocyst thing is kind of a big thing, okay? Blastocyst, at this point in time, there's a little fluid-filled cavity around the outside of cells that become placenta, and there's a little inner cell mass that's what's become your baby. And sometimes it starts hatching, and actually human embryos hatch. Kind of like we think only chickens hatch, but human embryos hatch too, so we'll sometimes see evidence of that. That is not a twin breaking off or something like that. Embryos are graded. They're graded by quality. There's grading scores in different centers, and different doctors use different grading scales. So this is just one example of, this is based on David Gardner, and they're graded 1 through 6, and then there's this ABC based on inner cell mass and trophectoderm. But you don't want to get all hung up about your embryo grade. It's nice to understand a little bit, because a really nice embryo does have a higher implantation rate, and a little lower grade embryo might not have as much. And then if you're having a transfer, I'll usually have a discussion saying, here's kind of what these look like, so that we're all on the same page of what expectations might look like, okay? Now, probably, a number of years ago, we put in 1 or 2 embryos, and we kind of hit the ceiling. Okay, we can get 50, 60% of people pregnant. We just could not get higher than that, no matter what technology we came up with, okay? From way back from first IVF for 10%, now we can get, putting in 1 embryo, maybe 2, you can get 60%, and then you're like, okay, we've got this glass ceiling, we can't get anywhere higher than that. So in the last few years or so, it's become appreciated that even embryos that look really beautiful might not be. All that glitters is not gold. You can't judge a book by its cover. That's kind of the adage. So this is just an illustration to say, hey, if embryos that look really great, look really beautiful, you're not just, oh my gosh, we've never seen such a good one in our life. We are going to put it on our website, because this is just what we want everybody to allude to. Holy Toledo, when we do DNA testing on embryos, we're like, oh, wow, 45%, that's almost half. 45% of those are aneuploid. Aneuploid is a fancy word for, hey, they are chromosomally not normal and not viable embryos, and are not going to give you a healthy live birth. So that was kind of scary to learn, like, oh, isn't that so interesting that 100 minus 45 is 55, and that's where we're stuck. We're stuck at this exactly, we're stuck at the glass ceiling. So we really thought we're onto something here, thinking, hey, but if we could try to figure out which ones are the normal ones, then maybe we can increase pregnancy chance. So you can see as embryo quality, this day 5 morphology goes down to poor. You can see, hey, poor embryo, 80% of those are not normal. Okay? So if you're putting in poor embryos, of course the pregnancy rates and the live birth rate is going to be lower, because even though we can identify it, we know that that is the case. And miscarriage rate is higher if embryo quality is not good as well. So one of the technologies that we've been doing for more than a decade, and I did it even before I came, I've been here 16 years and was doing it before I came to Kansas City, is embryo biopsy. We used to do day 3, now we do day 5. We've done day 5 for many, many years, but when that embryo is on day 5, instead of transferring it and choosing only based on the morphology score, right? That would be kind of like doing the Miss America pageant and only having the swimsuit competition to say, hey, who should win? Hey, let's know more about the embryo. It's not just looks, we want to know a little bit more, so we can actually sample a few cells, biopsy a few cells, and then run DNA on it, okay? So we assist hatches making a little hole in the zone and get a little sample of embryos, and they get shipped off and get some testing. So there's several of these labs that run the DNA testing results, and this is just a little illustration. This is the most recent data that's available because you have to wait for babies to be born and that sort of thing. So this is some national data, and what I'm just trying to illustrate to you is that IVF is great without testing. We can absolutely do without testing. The pregnancy rate is lower if we don't test embryos and goes down at a faster rate, as illustrated in this graph here, compared to, hey, if you put in a tested embryo, because the number one reason that it doesn't work when you get older is that even though the embryo might look beautiful, it may not be actually in DNA. So it's a technique that is available. It's not for everybody, but it is something that certainly you want to consider. By age, this is kind of interesting that, hey, even when you're like, okay, 33, like 40% are not normal. It's like amazing. This is already after the 12, and after the 6 mature, and after the 3, after they grow 5 days, and we're down to a few embryos, and then holy Toledo, 40% of those are not good, and that's only in a 33-year-old. And you look on this graph to go, okay, well, I'm 41. Okay, well, 75% will be abnormal by estimation, and we know a 41-year-old is going to make many fewer probably than somebody who's 33. So it's one of the challenges. This is the very same data in a graph form. So to give you some idea, for example, even in the youngest ages, under 35, and in healthy egg donors, about 32% of embryos that look beautiful are not. You can see by, say, 42, it's like more than 80% of embryos that look good are not. Okay. So if we put in a tested embryo, then we can put in fewer embryos and get a higher chance of a live birth. Okay. And sometimes we're even seeing pregnancy rates of like 80% putting in one embryo. No matter how old you are, no matter what your FSH is, no matter what your AMH is. So not for everybody, but for some people, I think you're starting to get burnt out. They've done a number of cycles. They're like, oh my God, I've been on this journey for like 7 years. I just said somebody yesterday, so we've been trying for like, actually it was like 9 years. We've done, these people had done a lot of cycles of, it was more than 20 of ovulation induction. And we're like, okay, I don't know what to do, and we're just so discouraged, and we're going to give up. And I'm like, okay, you might want to think before you get too burned out. And yes, it is more expensive than doing IUI, but if you're going to do 5 years and have therapy sessions and bring in Prozac and be depressed, and when you add all those things up, one of the paradigms now is like you move sooner. Most people are not going to need it, and you may never need it at all. But you just don't want to dilly-dally too long at this point in time where you're like 10%, 10%, 10%. Like, okay, some point in time, maybe you want to reach a little higher so that, you can have things happen. So one of the new paradigms for IVF is, hey, we moved IVF faster. It is a way we can get a singleton, healthy, full-term baby. Freezing of embryos, no longer an ugly word. It wasn't that long ago where you go, oh my gosh, we're kind of afraid to freeze an embryo. I have heard bad things about that, Dr. Brayback, and I think it's going to damage the embryo, and I don't know about that. Well, now there's newer techniques for freezing, which are much safer. Embryo testing has become less expensive, and it's becoming more common. And so, again, the goal is, hey, we've got a high pregnancy rate, low multiple. We want a high chance of a live birth, and we want to take home the baby. Okay? And that's all I have. So I just want to thank all of you, and I would like to thank my whole team. I could not do it. I've got a team of about 20, and they are all fabulous. And again, we're so glad that you're here today.